Thank you. It's really nice to be here amongst experts. Very good idea to have the subspecialty. Also extremely nice to see and happy to see Dr. Leone and his wonderful work. And thank you, Professor Siddique, to give an overview on how exactly management of thyroid eye disease. I'll try to delve into what is new in thyroid eye disease. And this is my only financial disclosure. Just wanted to say that I'll try to pick up things which are relevant to us. Otherwise, if you start talking about what is new in thyroid eye disease, you could probably start and end with teprotumumab. Essentially, when you are trying to put a patient into a classification system, you say this particular patient and you always kind of know which one. You should be taking the worst eye. But do you take the worst eye, you take the other eye? There are so many confounders. So essentially, what do? We know about several classification systems that exist, but all of them sort of have their own challenges in this one. So essentially, this is what we do. We try to sometimes, if it's a symmetric disease, follow the fellow eye and try to put it onto a classification system that works in sometimes. But a lot of times, actually, the deeper orbit you have access with a form of imaging, which you could possibly use to put a score and then plan a management. Most of the times when you have patients like this, you're definitely looking at decompression to save the eye, and you have quite gratifying results. The other thing that is important is not much is talked about this form of sight-threatening disease, which is corneal breakdown. We know about sight-threatening disease, DON a lot, risk factors and other things. But here, I think if you go back to the older classification system of Werner's, tends to talk a little bit about grading these into where you just have superficial punctate keratopathies, you have an added component of infection, which complicates things, and then you have an impending perforation or already a perforation. Whatever said and done, actually, the ones which are moderate to severe tend to do very well if you have a very expeditious plan, definitely constituting decompression, but more important than that, it is multiple things that come into play. The second point I want to bring in is Rundle's curve. Now, Rundle's curve in thyroid eye disease is like a religious dogma. And actually, we all talk about it. But I just want to bring in one new thing which actually is brought out in this particular recent report from Dr. Cruz. And he actually brings out where exactly did it start out from. And essentially, this was based on a series of articles from 45 to about 50, and several articles came out. But the key thing was there were only 12 patients and 24 eyes that we are talking about. This is a very nice read. I would definitely recommend this. But just to say that very few of those patients, based on the proptosis and others, actually fell into this biphasic course that we follow as a religious dogma. So essentially, whether we should only just keep thinking about this Rundle's curve and manage is a question, but a good read anyway. The third thing I want to bring in is a lot of people now depend upon imaging, MRI. There are several parameters we look at. What I've tried to show with a yellow arrow is a signal intensity ratio, which we tend to follow quite often. But again, a very nice article by Louis Mon talks about not only signal intensity ratio, where you compare the intensity of the extraocular muscle and compare it with one of the, let's say, a temporalis muscle or anything outside the orbit within the same field of view, but essentially also T1 and T2 relaxation times, which are helpful in putting activity, and that's really helpful. Another patient to show the same thing. But how it really helps is in this particular patient who has upper lid retraction. And based on imaging results, we tend to show a thickening in the SRLPS, very good results and gratifying with either a transcutaneous or a transconjunctival injection of triamcinolone in upper lid retraction. 4, well, the combination of steroid and mycophenolate in the 21 guidelines of UGOGO came as a big relief. Essentially because you have your own challenges of treating patients, particularly who are diabetic, and this particular helped. I'm trying to show one particular patient where we treated with mycophenolate and then moved on to doing a surgery. And this particular site was also showed by Professor Siddique. Essentially, it tells you that you can either look at combining IVMP with mycophenolate, and with the kind of safety margins that mycophenolate has, it definitely comes to our rescue. This is another patient that I wanted to show and came in with decreased vision, we actually did a decompression, followed him up with putting him onto a therapy on mycophenolate for about 5 months, and that's his. Essentially, the other thing is his right eye vision didn't improve completely. And something interesting, this was actually seen in the retina clinic, and they had done both the RNFL and the, and essentially what it showed in the right eye was there's a significant degree of thinning already. Now, the key point I want to bring in is there's a lot of literature already about the importance of the ganglion cell layer and the RNFL layer thickness. How exactly does it help? Would we have done anything differently? I don't think so. But the point to note is that this is a particular parameter that is very much in vogue and is being done in thyroid eye disease patients. Our own work has, of course, shown that the diabetes remains a major risk factor, almost as important to us or maybe more compared to smoking, doubles the risk of dysthyroid optic neuropathy, and our own work tends to suggest that you probably have to treat them a little differently. And the key things, there are a lot of things. Obviously, patients with diabetes and thyroid eye disease should be treated in a multidisciplinary clinic. But the key things are you have to probably look at what are the drugs you tend to take for diabetes, metformin preferred, look at the lipid levels, also very closely follow the blood sugar levels. But if you're facing a patient who has multiple risk factors, old age, diabetes, smoking, 2 or more, as we say, then it's better to probably think about surgery first and then put them onto immune modulation for saving the nerve, and particularly in sight-threatening disease. This is one particular patient where we had done early surgery, bilateral endoscopic decompression, and then put him on therapy, and he stabilized. What you're also looking at is trying to keep a more broader posterior orbit and decompression to get that effect, and that's what I'm trying to show on the scans. Last, you're talking about stage versus simultaneous surgery, something that we get stimulated for. We obviously know patients which are very long-drawn rehabilitative surgeries to correct them. And that's what we have always known, orbit, muscle, eyelid. Essentially, now there is a concept that you could have simultaneous surgeries, and this is one particular patient. We are just learning, but essentially, you not only take care of the orbit, but also take care of the muscles, and that's what he is after a sequential decompression, but the muscle surgery is done along with the decompression. Another patient where a customized surgery was done in thyroid eye disease, and that's her after the surgery. And again, another patient who had double vision to begin with, 30 prism diopters, and post-surgery in the right eye, she's single vision in the primary gaze. Teprotumumab, we all know, huge response. It's not available to us, but the most important thing is one of the few which gives a response in proptosis and looks like even beyond active disease. A little bit of a concern both on the hyperglycemia front and the hearing impairment that it causes, but something that we need to look out for. On our front, we can probably just use tocilizumab, which works not as much on the proptosis front, but we use it every now and whenever we faced with a recalcitrant patient who's not responded to either the combination of IVMP with MMF or is recalcitrant because there is a reactivation disease. This particular one had a thyroid nodule which needed surgery. So that's all I have in what is new in thyroid eye disease. Thank you.